Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Hello and welcome to another episode of Scrubs and Subpoenas, Tales from the Witness Stand. You know, Dr. Miller, I kind of want to do like a thunder sound every time I say that in the background. It just feels like we should do that. Welcome back. Thunder, boom, right? What do you think?
I mean, I always think of the tales from whenever I hear you say that, I think of Tales from the Crypt.
I think we should add it. We should definitely add it.
That'd be awesome.
Thank you for joining me, Dr. Miller. How are you?
I'm well, thank you. And you?
Good. Excited to hear these stories. I always really love tuning into these with you and learning. I learn something new personally every single time we walk away from this. So that's a good thing. So I think that's the point, right? To talk about these stories, right? To learn from these stories. We are all healthcare providers. I think I'm probably being biased in saying this, but if anybody knows like mistakes can be made, it's us. It's us on this side who are working with patients and people in real world scenarios every single day. Sometimes in environments that are so wacky, right? So wacky, because that's just the nature of the beast in some cases. So we know mistakes happen, and this is the time where we get to really talk about when they do, what can we learn from it? What are the takeaways that can help us to just practice better, just be a little bit better than we were yesterday, right? And for our patients, for everybody that we really are taking care of, including the facilities that we help to support. Anything you want to add to that, Dr. Miller? I always like to set the stage for everybody listening.
No, I think there is always something to learn, and it's easy to Monday morning quarterback and be very critical. And I like this particular case that we're going to talk about today. I think it's really, really instructive to look back at it. Not Monday morning quarterbacking, to the extent we can learn from it. So there is that. But it's also important to remember that the idea here isn't to criticize knowing what you know. It's to evaluate it from the perspective of the person at the time that they are providing care, and trying to consider what they were thinking, what that person had to work with. And so as we look at this case, I think there's just some good things to pull out of it for all of us. So that's why I picked it for us today.
Yeah, well, I think that's fair, and I'm excited to listen to it. So whenever you're ready.
Oh, I'm always ready. Now, what I take out snippets from my notes so that I can read things directly, because I really try not to infuse my personal opinion. You know, to some extent, when an expert writes a report, of course, it's called your opinion, but it's still supposed to be. I mean, it still should be unbiased and objective, and I guess prospective is the word, like you're looking at it through the eyes of the clinician, knowing what they knew or should have known, not what we know now a couple of years later.
And that sounds really hard. That sounds hard. So Dr. Miller,
it is really hard,
because that sounds really difficult to be unbiased.
And I think, well, there's that whole concept of implicit bias.
Yeah.
That we all have biases and don't even realize it. And I mean, listen, we can't control for everything, but the most important thing is to recognize that we do have implicit biases, and to just do the best we can to try to acknowledge that and recognize them and mitigate them as best we can. So the events of this case are really very short-lived. We just have a couple of days. The patient had encounters with the healthcare system on, 2 days, and then the third day the patient died. I guess I'm not giving away anything when I say that now. So I'm going to read some snippets to you from each day. This gentleman was in his mid-50s. I want to say 50s. Yeah, 57-year-old man. Excuse me. And to set the stage here, remember, I take out bits and pieces to share with our audience, like the most relevant stuff. But of course, the entire lawsuit, there is a bigger picture here. And one of the things that is very clear about this gentleman is that he's not a complainer. He was a stoic gentleman, stoic working class man, worked, with his hands physically and stuff all of his life, just a hard worker, a doer. And so he did not have a regular healthcare provider. One of the examples that his wife gave in her deposition was that a few years back, he had had some sort of acute orthopedic injury. I forget exactly what it was now, but something that the rest of us would take us out.
Yeah.
And he continued to work for 3 full days on his
my
physical job before finally saying, oh, well, I better go see somebody about this. And it turned out to be like an orthopedic surgery, like it was a significant deal. So he's he's a hardworking, stoic man, not one to complain, not one, to seek out health care. And so I think that's helpful background data. So what happened was, well, first let me just share with you the note, and then there's like some relevant pieces from the deposition testimony of his wife. And deposition testimony is sworn testimony, and it is taken as true. It is considered as valid of information as anything else that's part of the lawsuit. And so I guess so on the 21st of the month, on month X, on the 21st, the patient woke up with a headache.
Okay.
Well, the wife actually, when the wife was deposed, she said, well, he was awake first. And then when I got up, he told me he had a headache. So whether he woke up with it or it developed between the time he woke up and she woke up, who cares?
Right.
So in the morning of the 21st, he had a really bad headache. This man who doesn't complain, who worked through an orthopedic injury, first thing he tells his wife is that he has a really bad headache. He's not going to work that day. He's going to stay home. And she said, lights out, no noise. And he had a cool washcloth on his head. And that's how then she had to go out, and she worked part-time. She was out for a few hours.
Bad headache.
So that was bad. It was bad.
Yeah.
And it was all day on the day of the 21st. All right. So he continues to have the headache throughout the day and all night. So the next day on the 22nd, his wife takes him to urgent care. So the urgent care note, so this is the history of present illness, pretty much verbatim. 57-year-old male presents for a complaint of headache that started yesterday morning. Patient reports he woke up and had some neck stiffness that turned into a throbbing frontal headache. Since then, patient has developed nausea and vomiting and increasing pain. Patient does not have a history of migraines, but has had sinus headaches and other headaches in the past, has history of possible hypertension, but he has never been diagnosed as he does not see doctors frequently. Patient's father has a history of stroke, hypertension, and CAD. Patient has been under significant stress at work as well as emotionally as his father is preparing to pass away. Patient denies any change in vision, slurred speech, numbness, tingling, weakness, or loss of consciousness. So it's pretty decent H&P as far as H&Ps go. We could be critical, and I could tear it apart if I want, because I teach how to do an H&P and teach how to do a perfect one. That's pretty good for urgent care. No diss to urgent care, but urgent care is very specific complaint focused, and that's what we've got. The neurologic exam was documented as normal. No numbness, tingling, slurring of speech, facial, whatever. Okay, so that's that. He also was found at this time to have a blood pressure of 194/95.
Whoa.
The remainder of his vital signs were normal. He was awake, alert, oriented, etc. He was given clonidine in urgent care, and the blood pressure came down a little bit. I'm sure the numbers are here somewhere. It came down to below 180/120. I can tell you that. It was still high, but it came down after clonidine. And so he was discharged with a diagnosis of elevated blood pressure without diagnosis of hypertension, which, in your ICD-10 code world, that's technically correct. You're not supposed to diagnose hypertension unless the patient has elevated pressures on 2 separate occasions.
Okay.
Unless they have target organ damage, which there's no evidence of. So anyway, that's like neither here nor there. That was his diagnosis. He was discharged with lisinopril and instruction to establish care with a primary care provider. And that's that. That's urgent care. And that's what urgent care does. Urgent care has to decide, what the disposition is. Do you need to escalate it, or do you discharge it? But everybody should have a primary care provider. And so in the end, you're always advised to go follow up with primary care.
Yeah.
So that's what happened on that day. So patient went home. And now his wife, again, they're like simple people, simple working class kind of people. They were told to keep an eye on the blood pressure. So man, his wife is checking his blood pressure like, every 15 minutes.
Right.
She's taking blood pressure and writing it down, and they filled the prescription right away. And blood pressure was, it was still in that like 170, 180 range. But nothing else changed. Now, the wife in her deposition did say that this was a PA in urgent care. And she said that the PA said on several occasions during this encounter that she did not want to send him to the ER. She talked about the ER, but she didn't want to send him. The wife said it was almost like she thought it wasn't a good ER. But nobody said that. Nobody said that. That's just the wife's impression. But repeatedly, then she said the PA kept saying, we're not going to let anything happen to you, big guy. Like, don't worry, big guy. We're going to take care of you, big guy. Which, just as a side note, it reads really bad. It just sounds bad. Patients aren't big guys. They're patients. But anyway, she said she had the impression that like ER was on the brain, but she didn't want to send her there. Okay, so patient goes home with his lisinopril, and his headache is no better. And the next day, he gets some sleep off and on through the night. The next day, he wakes up and his headache is still just as bad.
No good.
So he's still sleeping. He's still laying in bed with a cold cloth on his head, and his headache is no better. And in the deposition testimony, the wife testified that when they were in the exam room and the PA was getting information about the headache, that the patient said, it's not like my sinus headaches that are here. And he indicated, the ethmoid sinuses, it's more here. Like he was indicating a frontal headache versus ethmoid. Okay. So the next day, the patient still can't go to work. He's still having head pain that is constant. So the wife calls, she goes to primary care sometimes. So she has a practice she's affiliated with, and she knows they can get in there that day. So just like they were told to do, she was very much like, they told us to do this, and we did what they told us to do. Right. She calls her primary care office, and she gets him in for an appointment that day. So you know how it is in primary care. If you want to go in that day, you see who's available. And in this case, it wasn't the person the wife normally sees. It was a nurse practitioner. So the patient goes in to see the nurse practitioner complaining of this headache. So this note, it's a single page note. It's harder to read because it's not electronic. I don't know why, because this wasn't that long ago. It should have been electronic, it seems like. But it wasn't. It's a paper chart, and it's one of those things that has little blocks, and then the physical's over here, and there's a little place for history up here, and there's this thing here. So I'm going to share with you as best I can. All right. The blood pressure today is 168/100.
Yikes.
Temp 90.1, pulse 64. Okay, that's fine. So under history, here's what, now this is a new patient. This is a new patient to this practice, and it's the first time, not just the first time that the NP is seeing him, but for the first time he's ever been there. History.
Oh, right, because not new to the wife, but new to him.
Yeah, so brand new to this patient. He's brand new to that practice. Patient to office to establish care. Patient seen in urgent care last night with elevated blood pressure, positive headache, negative visual changes, positive tinnitus, negative edema. And then the physical exam, there's a few circles around. The skin is warm, no acute distress, pupils reactive, lungs clear, heart regular. That's it. That's the whole physical exam. So that's the history, and that's the physical exam. And then under diagnosis and plan, it says diagnosis, number 1, hypertension uncontrolled. Number 2, fatigue. Number 3, nausea. Those are the diagnoses. Treatment plan. Number 1, EKG, and it showed sinus Brady at 56. Number 2, decrease salt intake, decrease caffeine intake, and decrease alcohol intake. Number 3, hydrate with water. Number 4, increase lisinopril to 20 milligrams a day. Number 5, use Fibercon for constipation. Number 6, start amlodipine 2.5 milligrams a day. Monitor blood pressure at home. And then return to office in 1 month to follow up hypertension.
Okay.
So that's that. So the patient, and now the wife said they were there for a long time. She said it wasn't like an in and out, that the NP was went out of the room to consult with the physician and then came back. And she said this NP on more than one occasion during this visit was sort of thinking out loud, like, why didn't urgent care send him to the ER? And then opined that she didn't want to send him to the ER. So the ER is on everybody's brain here. But for whatever reason,
oh my God.
And nobody wrote anything down. Nobody explained why. And so the next day, so the headache started on the 21st, the urgent care was on the 22nd, this visit in primary care was on the 23rd, and then the next note is on the 24th, when the patient presents to the emergency room. And so this note says, 57-year-old man with a history of hypertension was suffering with headache, was seen at primary care provider office where per chart review he had a systolic blood pressure of over 200, which he didn't. I don't know where that came from. Was started on lisinopril. However, headache worsened. Was seen in urgent care, neck stiffness, progressive nausea and vomiting, treated for elevated BP again and sent home. This morning he collapsed at home after the worst headache of his life, suffering a cold arrest in the field, pulseless electrical activity, got 4 rounds of epi, no shocks, was brought to the ER where a head CT showed a subarachnoid hemorrhage.
Oh my God.
CT angiography revealed saccular aneurysm and, blah, blah, blah. And anyway, the patient expired, patient died. And so you can, again, being objective here and thinking about what they knew, what they didn't know, what they thought, and what they wrote down. There's so many things that we can take away from this, because I read the deposition of the wife. I read the deposition of the nurse practitioner, read everybody's deposition. And I can tell you in summary, the nurse practitioner was thinking migraine.
Yeah.
Didn't write it down. Nurse practitioner was thinking migraine. I actually, last night, I honest to God, when I was reading the wife's deposition, I actually got teary-eyed, which I don't often do anyway, unless it's about a dog. But she was talking about how they planned to retire when he was 60 and, he was 57. I know, right? I can feel myself. And that now she just can't even think about tomorrow. She doesn't know what she's just getting through. The attorney who was deposing her said, you're just going day to day. And she said, I'm just getting through situation to situation.
Just left foot,
really
right
very,
foot.
very sad.
Oh my God.
So what do you think? Any questions for you, or any questions that you have?
So I got to be honest, the minute you said, and this is like the nursing school coming back, the minute you said the worst headache of his life, my brain said, that's an aneurysm. That's gone. Okay. The ER thing kind of makes me nuts. I got to be honest, because, and I think, again, I'm being biased. I learned just from myself that in work, right? Working as a nurse, if it ever comes up, if I ever think, just for an example, gosh, I don't know, I should really call Sally on this one. No, I won't. I don't know, maybe I should call Sally. If it comes in my brain, I have learned through a lot of different scenarios to just do it. To just do it. Better to have overdid it. I didn't need to consult Sally than to not. So that's an interesting thing that they didn't do that. And then the other thing, and I just don't know the rules on this, if someone has a headache that bad and their blood pressure is that high, is it inappropriate to do a scan of the head? Is that inappropriate? It's been he's having terrible headaches and really high blood pressure. Is that not a thing that you're thinking about?
It's so, when you put them together like that, I'm not entirely sure how to answer it. Just the very high blood pressures.
Yeah.
Just very high blood pressures, there is no reason to scan the head.
Yeah.
A high blood pressure with acute target organ damage, then yes, it would be appropriate. But then, there will be 2 schools of thought on this.
Yes.
There will be one school of thought that says that headache didn't sound like target organ damage, which we would think of as encephalopathy and mental status change and stuff like that. The one side of the coin would look at it that way. But with a headache and a blood pressure like that, I would, and I'm not just Monday morning quarterbacking here. Yeah. I would scan that head. But there are those who would say, but his mental status wasn't changed, his pupils were fine, and okay. Yeah. But the thing that really jumps out at me about this is that headache, because like anybody coming out of NP school, hopefully remembers that you don't start getting migraines when you're 57. See, this is where it's so easy to fall down a rabbit hole. Like the NP, she didn't like the note, like, listen, we can all learn about documentation. And I'm sure that the NP learned a lot about documentation. Many things, are learning curves from that. But one of them is that she went from headache to high blood pressure as a diagnosis. Like pulling off the urgent care note. The headache was the problem. That's the reason the patient was there, not his blood pressure. He didn't care about his blood pressure. He was there for his headache. Headache should have been the primary target there, and it wasn't. The blood pressure became the target. So that's where it's just good to remember. I think when we were doing documentation, I said the chief complaint should always be in the patient's words. Yes. Why the patient is there, because that keeps us grounded on the number one priority. It's a classic example of it. Yes. This MP went from here to here. And then the other thing is that maybe a lesser experienced NP might look at this and say, headache, nausea, photosensitivity. Like those are migraine. All classic migraine phenomenon. And statistically, migraine is much more common than a subarachnoid hemorrhage and all of that. But the thing that just really jumps out here that it's just so difficult to ignore is that the guy never had a headache like this before. And that's why it's so relevant that he's not a complainer. Yeah. That he's not, this man went from never seeing anybody for anything to having to stay home from work for days, this thing over his head, going to 2 different providers on 2 days because the pain is so profound and constant and intense. That right there, blood pressure or not, that right there goes in a scanner. Yeah. That is not a migraine. Yeah. And even, I think in the urgent care note, which really was pretty good, the urgent care note said he has no history of migraines, would get sinus headaches once in a while. And then one person might say, well, those things that he called sinus headaches, they probably were really migraine headaches. But again, it doesn't, this is the first time this is happening at 57 years old. Right. It needed to go in a scanner. It just had to go in a scanner. And for me, of all the other things that arise from this case, that's the biggest one. That's the takeaway. Don't let yourself get sucked down that rabbit hole of, headache, vomiting, or nausea, vomiting, photosensitivity, or whatever else I said, must be migraine because that's most common. Yeah. You don't want to ignore another really important feature of migraine is they virtually always begin in adolescence or young adulthood.
And that's
they
not
just
him.
Don't start when you're 57 years old. Mm-hmm.
This is a sad story. That is really sad. But you know what? And I would like to hear your perspective on this. Headaches seem hard. As a NP, any type of provider, headaches seem hard because in my mind, it's either nothing. It's a little nothing. You just actually didn't eat today. Mm-hmm. And that's your problem. You just need to have something. Mm-hmm. Or it's the worst case scenario. And I imagine that's something that NPs struggle with. Is that true? That when someone comes in and is like, my head hurts, what's a protocol for that? Then what?
Oh, yeah. Oh, no, there is totally a diagnostic evaluation of headache. And in fact, our own Wendy Wright. Yeah. Is, particularly skilled and knowledgeable about headache. And I think she does a lot of CE about headache assessment. And so for people that are really interested or feel like they need more info, that's definitely one avenue. I sound like a commercial here. I don't mean to sound like a commercial. I don't get kickbacks on Dr. Wendy's, but that's a particular area of expertise for her. Yeah. And for anyone who feels like they need some help with it, whether here or anywhere, you do want to brush up on it because there is an approach to the evaluation of the patient with a headache. There's definitely a diagnostic trajectory there. And it's true that, in the world of headaches, 99% of them will be what we call a primary headache, tension, migraine, or cluster. So just statistically, out of every 100 patients that walk into your office with a headache, 99 of them, it's going to be a primary headache that can be safely managed in the primary care setting. Yeah. 1 in 100 won't be. 1 in 100 statistically will be what we call a secondary headache or due to another condition. And that secondary headache isn't always an aneurysm. Aneurysms are things we see articles about and stuff. Sometimes people have a secondary headache because they have temporal arteritis or a true sinus infection or the flu or COVID or eye strain or a brain tumor or an aneurysm or a bleed or something like that. I mean, a secondary headache can be many things, and statistically overall, it's only 1 in 100. But there are certain red flags that should call you out to think, ooh, let me rule out this secondary headache. And the age of onset is one of them, because our primary headaches, tension, migraine, and cluster, virtually always. Now, every time I say always, there's always somebody who says, but I had a patient. In 99 parallel worlds, you don't start getting those headaches when you're 57 years old. And whatever else did or didn't happen in the past to this man, this is clearly and distinctly so different from anything he's ever experienced before, and has taken down this man who of some sort of knee fracture or something didn't take out before. Like that's all you need to know. That really does need to go in a scanner. Now, if it's not that bad, if somebody's having a headache and you go through your evaluation and you think, oh, this doesn't sound like, tension, migraine, or cluster, maybe it's more benign. Maybe is it a sinus thing? Is it an eye thing? There is a diagnostic pathway. And, NPs are taught this in school. And like I said, if it's something that pops up in your practice more often, there's lots of good CE about there. But there is definitely a way to move through the evaluation trajectory. But the first one is really the age of onset. And then the history. Like, you will have people with migraines that come in like that. They've been laying all night in bed with a rag over their head and they can't stand the light and they feel so sick to their stomach. Like, in many ways, that does sound like a migraine.
Yeah.
And if he were 14, or 19 or even 20, or if at 57, he was only there for pain management and says, oh my gosh, I've been getting these for 30 years.
Right.
This one's just really bad and I ran out of my med. Then you can call it a migraine. But when it shows up like that at that age and that intensity, it goes in a scanner. And even if it was 14, 15, or 16 or 20, if it was the first time they had that kind of pain, it still should go in a scanner. And then when you know that there's nothing wrong, and then if it happens again, well, that's where your migraine diagnoses come from.
Yeah. And really then taking too, because this is a good takeaway. I feel like sometimes providers do this, no disrespect to any providers, but don't really take into account the importance of what the patient is telling you. So to your point, this guy who's not ever complained and this from the wife, and you hear this, this person is not a complainer, he could take the worst of the worst. That is something that we need to consider clinically. I mean, it's not like a clinical thing, but I need to consider that this person could probably take a lot. So if this is something that he's complaining about, it must be really significant. We shouldn't poo-poo that.
And the note, the NP note, it didn't allude to any of that at all. It didn't allude anything about his headache. So the reader really can't, just documents no acute distress.
Right.
No, nothing about the headache. Now, it sounds like she was asking questions like that because the wife said he was indicating where it hurts and where it didn't. And she in her deposition said she was thinking it was a migraine. So there's a whole lot missing in that documentation.
Yes.
If her documentation supported a migraine, well, then you'd have a whole different story. If she wrote in her note, well, this is the worst headache, but patient has a history of headaches that he describes as, always thought they were sinuses. If there was some documentation to lead you down that path, well, then it wouldn't be such a clear-cut thing. But there's just, in this case, number one is when that kind of headache shows up for the first time at that age, into the scanner you go, off to the ER you go. And if you don't like the ER, call them up and say, I'm sending in this patient. He needs a CT of his head.
Right.
That helps for what it's worth. So that's one thing. And then the getting pigeonholed, going from headache to hypertension because of the last note. That's another takeaway message, and it happens all the time. Remember, we had a case some time back about a young woman that had back pain, and the first ER visit called it sciatica. So then for the next days, everybody kept thinking sciatica. Let's evaluate sciatica. Oh, the MRA does not support sciatica, and yet they got pigeonholed into that from the very beginning. We don't want to get pigeonholed. So this is just another good example of how that can happen. And then the quality of your documentation. We talked in our episode about documentation about how the note should, from top to bottom, you should be able to draw the conclusion. The chief complaint informs your history. That informs your physical. Even a pertinent negative. For somebody with this kind of head pain, pertinent negative neurologic findings are important, and they weren't there. And then all of that should lead to the diagnosis, you know?
And the one thing I don't think I heard, you may have said it, I could have just missed it, but if this was a migraine, I didn't hear migraine medications that I know anyway that I heard. I'd heard blood pressure medications. So like if you thought it was a migraine, would you have treated it with migraine drugs?
And then we don't know, and I don't necessarily mean this in a malicious way. It could very well be that when she looked back at it later, she thought migraine. You know, when she got sued and was looking back at everything like, oh, I was thinking migraine, but at the time didn't.
Yeah.
There's a lot of takeaways here for all of us.
Wow. So let me guess, were you on the plaintiff's side?
Yes.
Okay.
Yeah.
I can see that because I mean, this is a stark contrast to one of our episodes we did on really, really good, charting in that way. Wow.
Yep.
That's unfortunate. Dr. Miller, thank you for sharing this. This was a good,
always a pleasure.
A good learning opportunity, really. And I think some big things, especially listening to your patient, that comes up a lot. Like that means something. That really means something.
Oh,
well, appreciate your time. And thank you all for listening in. We hope you enjoyed this story and got some good takeaways from it. And check us out next week. Every Friday, we drop a new release. We hope you will join us for that. And in the meantime, goodbye for now.
This podcast featured content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.
Thank you.